the role of omega-3 fatty acids for the treatment and prevention of cardiometabolic disease. These are my disclosures. So the objectives of my talk is going to be to discuss the role of omega-3 fatty acids in maintaining cardiometabolic health and reducing residual risk, to cite the clinical trial evidence supporting the use of omega-3s in CVD prevention, and finally to review the randomized clinical trials currently evaluating the incremental benefit of adding omega-3 fatty acids to statin therapy in high-risk patients with residual elevated triglycerides. So this slide shows that something that many of you don't know, and that is that deficiency of omega-3 fatty acids is one of the leading causes of preventable death in the United States. And this led Dr. Mozaffarian from Boston to conclude that modest consumption of fish or fish oil, together with smoking cessation and regular moderate physical activity, should be among the first-line treatments for the prevention of CHD and sudden cardiac death. This was a recent study by Juan and his colleagues that really a huge study, over 1 million subjects worldwide, where they concluded that both fish and long-chain omega-3 fatty acid consumption is inversely associated with a risk of all-cause mortality. So the American Heart Association has recommended omega-3 fatty acids for healthy individuals. Their recommendation was to consume omega-3 rich fish like salmon at least twice a week, as well as plant-based sources of omega-3, which is alpha-linolenic acid. Those with documented CHD should consume about 1 gram of EPA and DHA a day, and those needing triglyceride lowering should consume about 2 to 4 grams of EPA and DHA a day. Now, how does it work? What's the mechanism of action by which omega-3s reduce cardiovascular risk? Well, I could spend an hour on this slide alone. This is an excellent article by Rafael de Catarina, who noted that omega-3 fatty acids lower triglycerides, reduce inflammation, lower blood pressure, lower resting heart rate, increase heart rate variability, and reduce the risk of fatal arrhythmias, improve insulin sensitivity, inhibit platelet function, improve endothelial function, and very importantly, reduce features of an inflammatory atherosclerotic plaque. Now, these are the kind of plaques that are highly inflamed that are more prone to plaque rupture. There's actually a rapid onset of action with omega-3s that cause steric interference in the ion receptors that raise ventricular fibrillation threshold and help to prevent sudden cardiac death. And a more gradual incorporation into the cell membranes that lead to long-term anti-atherogenic and anti-inflammatory effects. Now, with our obesity epidemic in this country, we've seen a rise in metabolic syndrome. And if you look at the impact of omega-3 on metabolic syndrome, it really hits many of the core issues. It improves insulin function, lowers triglycerides, lowers blood pressure, increases large buoyant HDL, decreases small dense and shifts it to more of a large buoyant LDL, less atherogenic, promotes healthy adipose function and reduces inflammation in adipose tissue. Martinez-Fernandez and colleagues published this article looking at omega-3s in people with metabolic syndrome and concluded that low-grade inflammation is a key factor for the development of metabolic syndrome, and dysfunctional adipose tissue, obesity-associated chronic inflammation, so that marine omega-3 fatty acids can attenuate adipose tissue inflammation and dysfunction. How about omega-3 fatty acids in patients with elevated triglycerides? Well, as you've just heard, triglycerides actually are causal. They increase CHD risk, and it's triglycerides, but especially triglyceride-rich lipoproteins. So what's the most common mechanism that we increase triglyceride-rich VLDL particles? It's really a flawed lifestyle that leads to adiposopathy or sick fat. And when these adipose cells start to hypertrophy, you develop insulin resistance. That takes the brake off of lipolysis. You get mobilization of free fatty acids. They go to the liver. The liver pumps out triglyceride-rich VLDL particles. Through the action of CETP, you swap triglycerides for cholesterol. Lipases act on both HDL and LDL, and it results in small, dense, more pro-atherogenic LDL and small, dense, less functional HDL. You also increase the number of remnant lipoproteins, which we'll talk about. Now, this is a slide that shows how triglyceride-rich lipoproteins are indeed atherogenic. When they interact with the vascular wall, they increase adhesion molecules, increase inflammation, oxidative stress, prothrombotic. They create endothelial dysfunction, and they increase permeability, so the remnant particles gets into the intima and are taken up by macrophages and contribute to foam cells, and then we're off to the races. Now, how is it that omega-3 fatty acids actually lower triglycerides? Well, I could spend a long time on this slide, and it's complex, but suffice it to say that omega-3s reduce triglyceride production in the liver, and they also increase catabolism of triglycerides by increasing or activating lipoprotein lipase activity. If you look at nascent VLDL, you can see that nascent VLDL picks up apolipoproteins when it leaves the liver. One of those are ApoC3. ApoC3 is an inhibitor of lipoprotein lipase. So by inhibiting lipoprotein lipase, you increase triglyceride levels. And this is interesting because this is a genetic study looking at loss of function mutations in ApoC3, which actually led to decreased triglyceride-rich lipoproteins, and as a result, a 40% decrease in the risk of coronary heart disease. Well, guess what also decreases ApoC3, omega-3 fatty acids. In the EVOLVE trial, as well as the ANCHOR and the MARINE trial, we saw a decrease in ApoC3 and therefore decrease in triglycerides. Well, how effective are omega-3 fatty acids in lowering triglycerides? This was a study by Bell Harris. It was actually a meta-analysis that he showed that EPA and DHA ethyl esters actually significantly lower triglycerides in patients with severe hypertriglyceridemia with triglyceride levels greater than 500 milligrams per deciliter by 45%. The problem is that if you look at LDL cholesterol, it also increased LDL cholesterol on an average about 40 to 45%, which complicated lipid management. So the MARINE study, again, looked at the same population, patients who had marked elevations of their triglycerides above 500. But instead of using an EPA and DHA ethyl ester, they used a purified EPA ethyl ester. And lo and behold, you still got a significant reduction in triglycerides, but you really did not impact LDL cholesterol. The other interesting thing is that if you look at inflammatory markers, namely hsCRP, as well as Lp(PLA2), you significantly lowered inflammation. Now, the real question, though, is, that's great for patients who come into your office with marked elevations of triglycerides, but what's the usual setting? Patients who come in with elevations between 150 to 200 and 500. I mean, this is a population that we commonly see, and this was the combos trial. These patients often are on statin therapy. So the real question is, what happens when you add omega-3 to existing statin therapy? Well, this trial showed that by doing so, you actually further reduce the triglyceride lowering, you further reduce non-HDL cholesterol, and in this trial with EPA and DHA, there was no significant impact on LDL cholesterol. So the ANCHOR trial, again, looked at this same population, those on with elevated triglycerides between 200 and 500, but this time with an EPA ethyl ester. These are patients, again, on statin therapy, and 4 grams of a EPA ethyl ester, again, lowered triglycerides beyond statin therapy alone, as well as lowering non-HDL cholesterol. It significantly lowered LDL cholesterol by 6%. And in addition to that, significantly lowered ApoB levels and lowered inflammatory markers. Well, one of the questions that's always asked is triglycerides independently linked to CVD risk? Well, we know from the PROVE-IT trial that that triglyceride levels were indeed related to risk, and it really supported the concept that achieving lower triglyceride levels may be an additional consideration beyond lowering LDL cholesterol in patients with acute coronary syndrome. Again, we're talking about how can we take residual risk off the table. Now, an interesting subset, and a lot of the clinical trials looking at triglyceride lowering, was those that had high triglyceride and low HDL. And one of them was the JELIS trial. It's a Japanese trial of patients that were at increased cardiovascular risk. They had hypercholesterolemia and placed on a statin. Well, this subgroup analysis of those individuals that had high triglyceride, low in HDL, who were then placed on an EPA ethyl ester, had a 53% further reduction in risk of a major coronary event. Now, that's very impressive, but again, this was a subgroup analysis, and we can't hang our hat on subgroup analysis, so the clinical question that we've been asking for years has been, is there indeed incremental benefit of adding omega-3 fatty acids to high-risk patients with elevated triglycerides who are already on optimal statin therapy for LDL cholesterol? And do we have a randomized clinical trial rather than a subgroup analysis that can document this? Well, you're not going to have to wait much longer, because right now we've got the REDUCE-IT trial. The REDUCE-IT trial is looking at a highly purified EPA ethyl ester in patients that are high risk, they with either CVD or high CVD risk, with residual hypertriglyceridemia, and on statin therapy for optimal LDL control. This trial is just about to be completed, and I suspect that we'll have the results presented at this year's American Heart Association Scientific Sessions in November. The STRENGTH trial is also looking at the same subset, and again, these are patients on optimal statin therapy. They're high-risk individuals with triglycerides between 200 and 500 milligrams per deciliter, to see whether or not the addition of an omega-3 was beneficial. In this case, this is an EPA and DHA carboxylic acid-free fatty acids. Now, this trial will probably be reported in 2019. As far as omega-3 fatty acids and hypertension, this colleagues showed that there indeed was a decrease in systolic and diastolic blood pressure and a modest capacity, about 4.5 millimeters of mercury of systolic blood pressure, which is commensurate with what we see with other lifestyle interventions. As far as sudden cardiac death and cardiac arrhythmias, this is a very interesting area. A lot of this bench research in this area was done by Alexander Leaf and his colleagues in the late 1990s, where they used canine studies to show that purified omega-3 fatty acids actually can prevent ischemia-induced ventricular fibrillation in the canine model of sudden cardiac death. As far as whether or not what's the results in humans, Siskovic and colleagues in Seattle, Washington did a study where they looked at the dietary intake of omega-3 fatty acids in those people who had out-of-hospital cardiac arrest. And they found that if you were in the highest level of omega-3 fatty acids, looking at the omega-3 index, you had a 90% reduction in risk of a primary cardiac arrest compared to those in the lowest quartile of omega-3 fatty acids. Insulin resistance and diabetes. The Origin trial looked at the role of omega-3 fatty acids in this group. Unfortunately, it did not reduce the rate of cardiovascular events in patients with dysglycemia at high risk for cardiovascular events. However, they used a gram of omega-3. Dekaterina in Diabetes Care said, was an interesting article where he still feels that omega-3 is worthwhile in diabetics as it lowers triglycerides, improves insulin sensitivity, it helps with plaque stabilization, and the like. Mozaffarian looked at a nutritional study where he noted that substituting carbohydrate and saturated fat with a diet rich in polyunsaturated fats, including omega-3 fatty acids, was beneficial in the regulation of blood sugar, improved insulin sensitivity, and increased insulin secretion capacity. Another very fascinating area is what is the role of omega-3 in plaque stabilization and regression? Well, Preston Mason and his colleagues at the Brigham did a really fascinating study where they looked at EPA ethyl esters, and they noted that decreased propagation of free radicals through the lipid bilayer and resulted in decrease in LDL oxidation and, very importantly, decrease in cholesterol crystal formation. Now, we haven't heard much about cholesterol crystals. I say it's one of the most neglected areas in cardiovascular research, because what happens when you get extracellular cholesterol concentrated and built up in an atherosclerotic plaque, it starts to crystallize. And these crystals, as you can see under electron microscopy, are very the sharp-pointed crystalline objects that can pierce the fibrous cap and lead to plaque erosion or plaque rupture. They also can activate the inflammasome in macrophages, which then activates production of IL-beta-1, which you're going to hear about in the CANTOS trial, and it increases inflammation within the plaque, which leads also to the increased likelihood of unstable plaques and plaque rupture. This was a study by George Abella and his colleagues at Michigan State, where they noted that crystallization of cholesterol in an atherosclerotic plaque can induce plaque rupture or erosion. And certainly, if you look at the overall atherogenesis, omega-3 fatty acids are very instrumental in helping to prevent all stages of atherosclerotic disease buildup. It increases antioxidant effects, decreases cholesterol crystals, decreases oxidized LDL, improves endothelial function. It decreases adhesion of monocytes and foam cells, and also decreases remnant lipoproteins. And in both the Jackson Heart Study and Framingham Offspring Study, we noted that remnant lipoproteins are actually predictive of incident CHD. And so getting our remnant lipoproteins down is important. It's not all about LDL cholesterol. So one of the other important studies was Thies and colleagues who noted that atherosclerotic plaques readily incorporate omega-3 fatty acids, inducing changes that can enhance the stability of an atherosclerotic plaque. And they went on to say that stability of plaques could explain reductions in non-fatal and fatal cardiovascular events associated with omega-3 intake. This study by Ando and colleagues, called the Cherry study, looked at adding EPA, again, a highly purified EPA ethyl ester. This was a study, a Japanese study, on top of high-dose pitavastatin in high-risk individuals. And they noted that by doing so, you got more robust plaque stabilization, but you also got plaque regression with the addition of EPA to pitavastatin. And it suggests patients with aggressive lipid-lowering therapy. So how about the clinical trials? I'm going to go through this quickly. We know that the Physicians' Health Study, which showed that just eating one fish meal a week versus those who ate one fish meal a month had a 52% reduction in cardiovascular sudden cardiac death. The Nurses' Health Study, 85,000 nurses, higher consumption of fish or omega-3 supplements associated with a lower risk of CHD and CHD death. This was a huge meta-analysis by Pennycrest Etherton, Bell Harris, and Lawrence Apple that showed that with over 250,000 participants, there was an inverse relationship between fish consumption and morbidity or mortality from coronary heart disease. Secondary prevention trials, such as the DART trial, showed a 29% reduction in all-cause mortality in those taking fish oil capsules or consuming fish over a 20-year period. GZ Prevention trial randomized 11,000 subjects post-myocardial infarction with one capsule of 850 milligrams of EPA and DHA. After 1 year, those taking the fish oil had a 21% reduction in total mortality, 30% reduction in cardiovascular mortality, and a very impressive 45% reduction in sudden cardiac death after only 4 months. The JELIS trial, which we talked about, this trial added EPA to statin therapy in a high-risk Japanese subset and noted a further 19% reduction in cardiovascular events. How about the risk of stroke? We know from the Nurses' Health Study that omega-3 fatty acids reduce the risk of thrombotic, not hemorrhagic, a thrombotic stroke by 50%. And Haynes showed that men and women who consume more fish had a significantly lower stroke risk, and again, this is thrombotic stroke. Heart failure, we know that omega-3 fatty acids have a modest decrease in mortality in people with heart failure, and it also helped to lower hospital readmission. There are some controversial studies that have taken place that really did not show benefit of omega-3 fatty acids, but these studies have been criticized. Several of them had very low omega-3 levels, some even less than 500 milligrams per day. Some of these trials also were very short time period and low-risk individuals. Some had problems by changing the p-value after the study from 0.05 to less than 0.05 to less than 0.006, and that was very highly criticized. But very importantly, a lot of these studies use supplements. Now, what's wrong with dietary supplements? Well, we know dietary supplements are not a substitute for prescription products. You know, they haven't been vetted. They haven't undergone the really close scrutiny that a prescription omega-3 has. And really, there's 4 pillars of omega-3 quality and safety. The first is potency. For a given fish oil capsule, you have to know that there is that it's highly concentrated in EPA and DHA. Purity is very important. You have to know that that fish oil capsule does not have a high concentration of saturated fatty acids and trans fat, as well as PCBs and dioxins. Stability is very important. You have to know that it's not oxidized. These, fish oil capsules that cause people to burp and have a fishy type of taste, a lot of these are highly oxidized. And of course, the final one, they have to be free of heavy metals. But I can assure you, if you take a fish oil capsule, and that capsule is highly oxidized fatty acids, and it has a high concentration of saturated fat, you are taking a fish oil capsule that really can go from being anti-atherogenic to pro-atherogenic. So there are organizations like the International Fish Oil Standards Program that rates all fish oil products. There's no charge to this. You can look this up online. And it's let the buyer beware. You have to be very careful with fish oil supplements. Another question is, should we measure omega-3 blood levels? And this study, which was done at Harvard with Christine Albert and Paul Ritker, looked as part of the Physician's Health Study, looked at omega-3 levels. And this is very similar to the Siskovic study that I showed earlier. They found that if you were in the highest quartile of omega-3 index, you had a 90% reduction in risk of sudden cardiac death compared to the folks in the lowest amount of omega-3 index. And this prompted William Harris and Von Schacke to state that we propose a new risk factor to be considered for sudden cardiac death, the omega-3 index. An omega-3 index of greater than 8% is associated with a 90% less risk for sudden cardiac death as compared to an omega-3 index of less than 4%. The omega-3 index as a risk factor for sudden cardiac death has striking similarities to LDL as a risk factor for coronary heart disease. Finally, it's important to also know that your omega-3 level is going to be in part a function of intake, but also whether or not there is polymorphisms of the desaturase enzymes that are very common, as well as whether or not there is any problems with gastrointestinal issues such as pancreatic lipase deficiency. And all these play a role in what your omega-3 levels will be. So the important point there is you really need to measure omega-3 levels to be certain. So in conclusion, the vast majority of clinical trial evidence supports the use of omega-3 fatty acids to lower CVD risk factors, to reduce residual risk, and lower major adverse cardiovascular events. That omega-3 blood levels vary widely due to differences in intake and genetics, and clinical studies have demonstrated the importance of measuring omega-3 blood levels and suggest that low omega-3 levels can potentially serve as a modifiable CVD risk factor.